Uh-oh. Can you hear me? Can you hear me? Hold on. We just went through this. Okay. Can you hear me now? No. Okay. You're not hearing through Clubhouse. Uh, I hear you pushing buttons, I think. Hold on. You're not saying, say something. I can hear you.
You can hear me, but I can't. You're not coming through Clubhouse at all.
Okay, hold on. Let's see. Why am I not coming through? Can you hear me now? No.
Now, I've unmuted through StreamYard. I can hear you, but I can't hear you on Clubhouse at all. I can only hear music, but I can't hear you. Tara, can you hear me?
I can hear you.
See, we're having technical difficulty. Clarice can't. I'm not hearing her through Clubhouse, but I can hear her through StreamYard. So just bear with us. I can't. I can't. Now I can't even hear music. Hold on. Let me mute myself. I can't even hear music now.
I don't hear anything.
Oh, that's because I muted myself so I can talk to her through StreamYard.
I don't hear music. I don't hear anything.
Me either. I'm, you know, for StreamYard, put up the chat so I can type it so we can type in the chat because I can't hear you. Oh, you said you're gonna leave and come back? Okay. Try that.
And maybe she needs to leave and come back in it.
That's what she's getting ready to do.
Can you hear me now? Yeah.
Oh yeah. All right. Let me mute myself again.
Oh.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
I, was studying for my certifications, years ago. And I never, ever, ever, ever heard that the use of the modifier is tied directly to the number of global days.
Mm-hmm.
I had never, ever heard of that, ever. I was always under the assumption, and all the questions that I've ever answered, I just assumed that if someone had a lab or if someone had a procedure done on the same day as an E&M, you automatically appended the modifier 25, which is not the case according to the modifier 25 fact sheet that was put out by Novitas Solutions, which is the MAC contractor for Pennsylvania, New Jersey, and I think Delaware.
Yeah.
So when I looked at the sheet, first of all, I found out about this through a LinkedIn article because there was a gentleman had made a post talking about how when as an auditor, when insurance companies see the modifier 25 overused, that clues them into, that triggers that provider for an audit, which I didn't know. And it kind of makes sense. So they have a very nice chart, flow sheet at a flow chart at the end of on the second page of their fact sheet that gives you a flow of how to determine whether to use the modifier. And they have an additional document that you have to look at. It's a spreadsheet. It's called the National Physician Fee Schedule Relative Value File, and it's updated annually. You can go and download it off of CMS's website, and every CPT code that they have several columns, and one of the columns is global days. So if you look up your CPT code and there are 3 X's, that's not eligible for the modifier 25. If it's 090, which is 90 days, it's not eligible for the modifier 25. You're only eligible to use the modifier 25 if the number of global days is 000 or 010, which is it was mind blowing when I read that and realized that. Then I just started looking up CPT codes that I have even told people to use a modifier 25 for. And when I looked it up, they have no global days, so it's not necessary. I was just completely shocked. And also I have to say that this varies by MAC contractor.
Mm-hmm. Mm-hmm.
So you have to find out in your area what your MAC contractor requires for the use of the modifier 25. And they will have guidance just like Novitas Solutions does. And it would be in your best interest to get that document and to follow it.
Yes, yes. That was when you sent me, I was like, sir, yes. And remember, I always said that's the importance of knowing the why behind what you're doing as it relates to coding, because they give you rules, they give you things that you need to follow. And if you, to your point that you made to me earlier, this is probably why the whole confusion with appending modifier 25. If you knew some of the background and you knew some of the history, then you would understand. Because to me, it's like, well, I don't understand why they don't get when to add it and when not to add it.
Because it's not taught. It's not taught like that.
It's not taught like that. And I remember something like that. But then also some of the EMR systems, they're like automatically put it, like it won't let it go through unless you add a modifier 25 to the E&M to attach the procedure with it.
Yeah, then that's a flaw there and it's probably due to
The way they
built that software. And so it will take a person to go in and manually remove them.
Mm-hmm.
Yeah, that's a lot. Especially if they're automatically appended and you don't know. And say it's a service or something that you are not familiar with and you don't know that the modifier 25 has been added, and then you get paid and then you continue to get paid, and then all of a sudden you get a notice and you get an audit and down the rabbit hole you go.
Now, also on that fact sheet, which was interesting, well, I knew that for other reasons. It just made sense for other reasons. But the it used to be the nurse visit code, but 99211.
Mm-hmm.
You are not allowed to use the modifier 25 for 99211, which
Yeah.
makes sense because the modifier 25 is for you have to have a separate E&M service. 99211 is not in service because it is a non-physician visit.
Correct.
So I just knew that just from the nature of the visit that you couldn't use the modifier 25. But when I saw in their documentation that you cannot append the modifier 25 to that particular code, I'm like, well, that makes sense. And I've had people ask me, especially, I was talking to you, Clarice, about COVID billing. And you have people who have asked me about appending a modifier. No, that's not what it means.
That's not what it means. And I think there were some other codes that it specifically expressed that you could not add the modifier 25 to on that checklist.
To any new patient codes, they are automatically excluded. They said it's automatically excluded from the global surgery packet, and that gets billed separately, differently, if it's a new patient.
Another thing you mentioned, which is kind of an aside, but I talked about in my video this week, I talked about the changes to critical care services. And just like you mentioned today, the variance from MAC to MAC is killing us. So while CMS have made these changes, some of the changes are not even represented in the CPT book, and probably for good reason, because they are CMS regulatory changes. Remember, CPT and CMS don't always jive. They don't always match. They don't. And if you want to get paid, you better make sure you follow the regulatory information by the person who is telling you what to do in order to get that dollar. Let's start there.
Right.
But the biggest piece, and while this is still an issue and while people are still talking about it, is because the MACs have interpreted things different. So one MAC believes one thing or is telling their folks one thing, and another MAC is saying, well, no, I didn't think it meant that. And telling somebody something else. So I think the onus on all of that comes back to the parent, CMS. I need you to educate your staff and your MACs so that everybody is on the same page and everybody understands, and not to leave these interpretations to the MAC. And same way with modifier 25, there is a lot, this has been going on for decades where folks are getting caught up with modifier 25 issues. So again, from a coder perspective, understanding the why behind what you do is key and important, but also unfortunately, we are part of the education. Well, we've become part of the education process as well, because sometimes we have to tell our Max, well, wait a minute. The guidance says blah, 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 blah. And, that's where, those appeals and having those conversations come into play, because your interpretation may not necessarily be CMS's interpretation, which may not necessarily be our interpretation. So it's a big circle. It's a big circle, and it's crazy. Crazy, I tell you. But like you said, if you're an auditor, you can retire. Probably sooner than later.
Definitely.
Yes. So we have lots of. Go ahead. I'm sorry.
Go ahead.
Proceed.
But that's what I really enjoy most about being a coder, is that you never stop learning.
Nope.
And if you are just a naturally inquisitive person, this is definitely the field for you, because you can sit in front of your computer and put in some searches, and you can go down a rabbit hole that you'll be down there all day and half the night. And what you will find will be mind blowing.
Were you there all day and half the night? I know you were there all day. I didn't know you stayed up to half the night.
Because then it leads you to other things. And then I went back through this person's thread on LinkedIn, and then he even had more information about, because you know when you call, even when you call like a Mac, or when you call an insurance company, you really don't know that the person that you're speaking to. You ask them about a code, you don't really know if they're telling you the right information.
Right.
And exactly what he addressed.
Right.
He has there's a spreadsheet, there's an Excel file that has different people who work at different Macs that you can contact for specific questions. I was like,
Mm-hmm.
oh, this is amazing.
Like there's a lot of information out there. Again, and some of it unfortunately is kind of like on a need to know. So say you are in a role and you're a coder, and the only thing really you're quote unquote required to do is just code those claims. They may not, that may be management's role to get the additional information or do some of the reaching out and um getting an understanding of these interpretations from those Macs. However, you as a coder have a personal responsibility to make sure that you are informed about what's happening and what's going on. And again, the why behind what you do. So maybe you're not doing it on the clock, maybe you are, but maybe you're taking the additional initiative to get an understanding. Look, I really want to know why we can't do XYZ, or I really want to know why they keep saying that we supposed to do XYZ. Again, that curiosity and that just that desire to, again, wanting to know more. And then of course you can share that information. You become part of the education process, like I mentioned before. Share that information with your teams. You make yourself valuable. You make yourself marketable. Come on, y'all. Come on, y'all. Come on, y'all. We level up. I feel Sierra in my level up, level up, level up.
Case in point, can I at my job this week there were a couple of coding issues. So one was this person had established, well, they had peripheral neuropathy as a result of falling off. It said falling off a mountain.
Mm-hmm.
That's what it said.
Wow.
So when I was contacted, the coding manager had said that they found this code. So when I looked up the code, I'm like, that says falling off an embankment. An embankment is not a mountain. I said, so that's definitely not it. So there was no specific index for mountain, but there was one for cliff. I said, now cliff is a little closer, and I can rationalize a cliff and a mountain, but I can't do, an embankment, because an embankment could be 2 feet or 200 feet.
Correct.
So, but it's just interesting how, how people don't index, and you really have, because it was because you had to find embankment in a different place than where you found cliff. And I'm like, just go by what is documented. It says fall off. So there's an index. There's a
the external causes.
Right. In the external causes, there's the main term fall, then it's from, off, and something else as one indent level. So from there you can find cliff. And I'm like, it's this simple thing.
But we talked about this, I think, last week. Folks don't know how to use their coding books because they don't use coding books. They're relying on the computer, which is great. And I think I'm trying to think back to when I used a coding software. I believe there was an area where you could actually go and reference the index. So there may be options, but again, you have to know that software. You have to know that program and know where to find things. Just like you would need to know where to find them in your book, you need to know where to find them using that particular software. And so if you don't know, have somebody tell you, have your trainers let you know, hey, you train me on how to get in here and make sure I'm coding this and where to apply the codes appropriately. Show me the rest of it. Show me the additional stuff. Again, make yourself marketable. Show me the rest of this. So when you go from system to system to system, you know, hey, I know somewhere in this system, probably in every system, there is kind of a resource bank or a reference bank or what have you that will get you to the various indexes so you can go through and look for yourself. Also, and I think I talked about this maybe a year or two ago, there are several wait, the government recently released one. I think I talked about that last year. But anyway, there's several online resources for ICD-10 coding that are free. And so they actually have the different indexes as well. So even if you don't necessarily know how to find the information in the coding software that you're using, you can kind of have a backup plan. My initial backup plan would be get that book out and dust it off. But as a secondary, there are some actual coding softwares online. Like I said, the government released one. I'm drawing a blank because I hadn't meant to talk about this today, but I'll put a link somewhere if you want to see what that looks like. And I think I even did a walkthrough so you can see how you can find the information that you're looking for in the coding. So I'll put a link in the description for the replay. But yeah, this was good information.
I think one of them is called ICD-10 codes or data. ICD-10 data.
Mm-hmm.
And I think it'll help you with all of them when I'm as confused.
I just use the book.
The book is my favorite, but I have been somewhere where somebody has asked me on the fly about. I'm like, what?
I like though, even though they take up so much space and you leave little white droplets everywhere. But I like my books.
I have yeah, they do. I'm still vacuuming up from the CPT book, but I have ICD consult on my phone, and it updates automatically every year with the new codes and provides information. And then there's another, like I said, there was one that's specifically provided by, I don't think it's HHS. I don't think it's, oh, this is going to drive me crazy, but it's actually provided online, but it's a government. And I think they did that too, because you can go back several years and look at the different various code sets as well. So if you like the purge, like I do every now and again, like, why am I still holding on to a 2015 book? But anyway, you can go back several years and it's online. And so you can still have the same information and regulations and guidance that you used in 2015, but you don't have to walk around and carry that book. I can't think of it, but I'll post it on the thing. I don't want to belabor the topic. Any questions or concerns or issues about that? Modifier 25? It was a good checklist though. One thing I want to do is kind of go and compare some of the various Macs and see what they have available to assist.
But I really like that flow sheet, that second page. That was really helpful.
Mm-hmm. And is that the one? I saw something that actually had examples too. So they provided some examples for using that flow sheet. Where is it? Using that flow sheet. If I can bring it up. There was something else I found. Using that kind of flow sheet, there were some specific examples. So if this and that, should you use modifier 25? Yes or no? And then they walk through the rationale for that as well. That was good. Good. Okay, so the last thing that I wanted to bring to your attention is, because I know we got a tight hour today.
No, it could be a little longer. We had people,
because somebody is hosting their own little show I'm gonna say little. Somebody is hosting their own big show today. And then we all got to be there and support and check in. So yes, I'm excited.
So these folks look like I think they got questions, so we will see.
We got questions. I'm sure we do. We do. Okay, so the last thing I want to say, and I'll really open it up for questions today quickly. The important message for Medicare. They're changing. There's some regulatory guidance that's coming down the pike that's going to be effective April 1st. You know, everything is going to be effective April 1st. It's going to be a madhouse in
Yeah.
April. And so the important message for Medicare, if you don't know, it's a document that's provided to all Medicare beneficiaries who are hospital inpatients. The form provides information on their hospital discharge appeal rights. So, for example, if the hospital is discharging you and you feel you should stay longer, then you have a right as a Medicare beneficiary. Actually, you have a right, period. But you have specifically for Medicare Medicare beneficiaries. Say that fast 3 times. The right to appeal. Um, and so CMS has recently changed a couple of things, and I'll just hit some of the highlights. So if you uh, are a patient who elects the hospice benefit as a formal exception to it, it's now a formal exception to providing the IMM, and that's what it's also affectionately known as, the IMM. So this would imply that a patient admitted to an inpatient hospice bed should not receive an IMM, nor should an inpatient who elects to discontinue curative care and enroll in hospice receive a follow-up copy of the IMM. Another thing that has a lot of teeth and a lot of conversation, and folks have been reaching out to CMS and trying to get clarification on, is those patients that change from inpatient to outpatient, where their status is changing and they're using condition code 44. Since patients whose status is changed from inpatient to outpatient via the condition code 44 process do not have expedited appeal rights, according to CMS. There is a federal court case that's currently pending in which petitioners are attempting to require patients whose status has changed from inpatient to outpatient to be allowed to appeal their status change. So there's a whole bunch of information and drama related to that. I will definitely, I'll probably do a separate video with all of this information, but I'll definitely post the document in the notes. And any thoughts or questions or concerns about that? So it's a whole bunch of stuff going on. And go ahead.
I mean, April's going to be really busy.
I know. Inpatient, outpatient, physician side, everybody gonna get it. Everybody is getting it.
And then now we even have where they're going to start to introduce new codes in April and October. So they're going to have new codes that are going to come into effect.
Yes, and they've already trickled a lot of those that, they're trickling them down slowly but surely. Like every couple of weeks you hear about some new codes. So it's going to be fun. Have a lot. And folks, if you're not paying attention and not keeping current with the issues, folks going to get lost and they'll be doing some things. And it's like, oh, well, we didn't know that there was a change. Yeah. Yeah. Things are a changing. Things are changing
quickly. So
if anybody has any questions or comments, feel free to come up to the stage. Now is the time that we have our Q&A or check in or just say hi or what have you. I think, Jesse, I got you as moderator. So if there's folks who want to. Hello, everybody.
Oh, now they want to be quiet. See?
Did we go through this last week?
Yeah, I'm sure they got
I done cut my whole section down to allow for Q&A. Oh, yeah.
But I do. Well, while we're waiting for people to ask questions, what I really want to say, especially to anybody in the audience who is a coding student or a new coder, you have to develop what I heard this earlier this year, and it has stuck with me. Success is a system, and when you work as a coder, you have to have a process that you use each and every time without deviation. because what happens is when you deviate or you don't go through step by step, you end up missing something. And like this week, I had, I was ahead of the game with my CDI work, thank goodness. So they had me doing doing some auditing for these new coders.
Look at you acquiring
So,
some additional skills. Look at you.
so uh, I've done it before. I don't really like to do it, to be honest.
Really?
Um, so this particular coder has been there almost 2 months, and I had 5 charts because the coder manager got busy. So all 5 of her charts, something was wrong, and I could tell, and it wasn't like it was the same thing. So you can see, okay, well, she needs to work on this. It was just random stuff, and what I took from it was, I'm like, she doesn't have a system. That she didn't have a process that she works through for every case that she codes. She's just looking, because it's too random, the things that are being missed. And I mean, it covers the gamut. Like, somebody is clearly, the person is it says, non-smoker, but she put down former smoker. Like, that's just attention to detail.
Right.
And you have to know, like, I don't think any coding students don't really realize how important it is for you to know those causal relationships. And you have to know combination codes, like you have to, because providers are not going to document in the way that we would like them to. So that's why they want you to know the causal relationships, and they want you to know these combination codes, because you have to identify them when you see them.
So wait, folks think that they're going to get their documentation just ABC, straightforward, straight out, just handed to them on a silver platter? Really? Is that the thought that's going on out there in
these worlds? But it has to be, because if it's not laid out like that, they miss it. Like, for instance, like, one of the charts had type 2 diabetes with CKD. It had diabetic peripheral neuropathy. They had diabetic retinopathy, all type 2. Then they have down there peripheral vascular disease, I-73.9. No, ma'am. That's E11.51. Things like that. Like, you have to.
And see, there's a reason why not only do you need to learn medical terminology, but you also need to know anatomy and physiology. And you need to understand how things are connected and how they relate. While again, if you're sitting for a coding examination, you may only be asked a few questions related to those, but you still need that knowledge base as a coder in your day-to-day job, in your day-to-day activity. It doesn't go away just because you're no longer sitting for a coding exam. It stays with you. It's part of what you need to know, and what you need to part of your coding toolkit, I like to think of, that you need to possess in order to do your job and be successful at doing your job. And add that into the system that he mentioned. I have a system too, even though my system failed this morning because we couldn't speak on time. But yeah, I'm all about the systems. You do this and this, then this, then this, then this. Voila, success. But yeah, those things learn. And even with anatomy and physiology, I mean, things change. Now, our body stays the same, don't get me wrong, or we're not peripherally, nobody is growing extra things that is now being genetically mutated throughout the masses. But the different services and procedures and different things, those things change. And so you have to stay on top of those things. You check in with your providers, say, hey, wait a minute, I see you're now doing this new surgery or this new procedure. Have conversations. Every conversation doesn't necessarily have to be, you didn't code this correctly, or a query about a code. conversations, they like to talk about what they do and themselves. Let them talk. And you get that information like, oh, because that information helps you become a better coder. Because now you're armed with some of the thought processes behind why they're doing what they're doing in that particular procedure that they may not necessarily write down. They may not necessarily document all the A, B, C, D. They're giving you a high level summary so you can get enough information to glean on how to code that. So, sometimes it's just a matter of having a conversation.
Right. So then I wanted to tell you about a situation we had. Now this is all, with everybody's a credential coder, and this was involving my our coding manager. So the coding manager and the director. So the coding manager had contacted me about anemia and chronic disease. So the provider had documented anemia and chronic disease. So when you go to the tabular, you have to code first the underlying condition.
Mm-hmm.
The provider did not identify the underlying disease. The person had CKD, the person had hypertension, diabetes. It could, so it's not, so can you believe the coding director told her to pick one?
Wow. Not pick one. Roll the dice, girl.
As opposed to, because she didn't want to query the provider, because when I first started, I created the query program. They didn't have one at all. Created templates and everything. So the feedback that I'm getting is the providers don't like it. Okay, but no provider ever likes being queried because they don't like being held accountable.
Mm-hmm.
It's just that simple.
Mm-hmm.
So what's interesting is the coding director never asked me about the scenario. The coding manager is the one who reached out to me.
Wow.
So, because I told you it's a little, I told you what was going on. So, I'm totally out of the loop. Like if I don't know, if I don't hear it from the coding manager, I don't hear it at all.
Wow.
So,
wow.
And that's fine, because guess what? I like those deposits every 2 weeks. And when I tell you I'm not working hard, I promise you I'm not working hard. All glory to God for the time being. So
yes.
But it's like you have to. I don't understand. I really don't. It's not. It's not as hard as people make it out to be. But when you don't follow the rules, you will always get into trouble. Always.
That's true.
And you cannot work outside of your scope. If you are not, we are never, as coders, not even as nurses, can you diagnose.
Correct.
That's not what we do.
That's not your role.
And when any documentation is unclear, it is your role, it is your duty, it is your obligation as a coder to query.
That's right. Remember, we have a standard of ethics.
Mm-hmm.
That outlines, what your responsibilities are as a coder, as a professional. You're absolutely correct.
You have to know, and you have to be empowered by the rules. I mean, I have been places where I've told people that might be what you want to do. I'm not going to do that.
Not that might be what you want to do.
Right. I'm not doing it, and I wouldn't. If you want to go and change what I do, that's fine, because that's why they have computer forensics. They can see that somebody went in after me and changed it, and it wasn't the same ID number. So go have at it.
Right. And I know when I provide recommendations, my thing is I'm always going to document. You have
That's
a choice to do whatever it is that you want to do. My job was to provide you with the information, and you can do whatever you wish with that information.
That's right.
Wow. Tara had to jump off. So no one has any. Go ahead. I'm still looking at your people. Nobody is wanting to come to the stage. Y'all scared? Y'all nervous? No questions? Well, maybe we were crystal clear on everything that we talked about today, and they got it down. They good. We need to be asking them some questions. How about?
Look, they are modified 25 pros right now.
Not Might have fired 25 pros. Wow. So how are you about your upcoming show?
I'm actually I needed to do it because I need to like start engaging with my platform,
Mhm.
and other than just putting up videos. And I have these classes where I teach people, but I never really have anybody on. I never really interact. So that's what I want to start doing. I want to start bringing in people that I have worked with in some capacity to kind of get their feedback on how they transitioned into the industry, like different things, like what kind of skills would they recommend someone have as they're transitioning. So I'm just trying to like just increase engagement and just try to give some more value, because people have a lot of questions, because change is always scary for some people.
Mhm.
Well, scarier than for some than others.
Okay.
It's always a little
It's
scary.
always
So,
scary. It's
and
always
some
scary.
people let that fear paralyze them, whereas others, and if you can have somebody talk to, give you their perspective of how they did it, and it kind of makes it, you kind of see that it's doable, and it kind of gives you a little more confidence to move forward. So
So are you talking specifically to nursing professionals?
actually, this one today I am, but what I'm also going to do is I have another one scheduled, I think, for like 2 weeks.
Mhm.
One of my former students from the college, because I think because there are skills that you have to have, I think, when you are coming into it as a nurse versus when you come into it as a lay person,
Okay. You're
because
right.
I think you have different skill sets.
And how often are you having your show?
I want to say like every 2 weeks.
Okay. Okay. So yeah, check out the coding nurse and his YouTube. Now, is it only going to be on YouTube, or will you broadcast in other places?
It's only going to be on YouTube for right now, because that's really the only place I really interact. Because I don't. I mean, I could do IG, but I'll stick to YouTube for now. Then if it's starting to grow, then I'll do YouTube and IG.
Yeah, IG is a whole animal in and of itself that seems very time consuming to me. I don't I was like, between IG and I guess the other thing is I'm a seasoned woman. My children are grown. I'm seasoned. So I'm like, between that and TikTok, and I was like, first of all, let me just say, I'm not gonna be dancing for a code. Nobody is doing that. I see folks just, trying to. No, ma'am. No,
Yeah.
sir. When I dance, it's for my own personal gratification. It
Right.
has nothing to do with the work. So, and if you catch me in these streets, you better come and dance with me. But anyway, um, so I was just like, and so I see the benefit and I get it. But I don't know. I just I have a different mindset, and I try to provide a different level of information and conversation for folks. So,
Well,
uh,
I also want to give out a little tidbit of info.
mhm.
Are you aware, Clarice, that there is about to be a mass exodus out of nursing?
Y'all been exiting forever, but
Oh,
y'all trying to come over here in our space. No kidding.
that's what I'm telling you. That's what I'm telling you. Like, anybody in the audience, if you are trying to get into HIM, you best do it now, because what is about to happen, and I think it's going to happen. Everybody has been talking about all this money that these nurses are making on these travel assignments.
Mhm.
Well, the hospitals in some states have started to use their political clout. They want to pass a law to cap travel nurses' pay.
Oh, so it's getting serious out here in these
It
streets. Oh,
it's
wow.
getting ready to go down. It's getting ready to go down. And when they limit these people's pay, what's going to happen is people are going to stop traveling. These hospitals are going to be extremely short staffed, because they're not going to pay more money, or they're not going to pay the money that they should pay, which is why people are traveling in the beginning.
Mhm.
So it's going to become problematic. And I'm telling you, like, I've always had people go to my website and send queries,
Mhm.
but the amount of nurses that are contacting me about becoming coders now is it's like a couple every day. People so if you're already out there, if you're already in school, finish it, get your credential, and get in the industry before these these nurses come in because they are lined up.
Wow. Interesting. Do you know what states are involved in that legislation?
I want to say for sure California because they were the first ones that I heard about lobbying. The hospital association in California was lobbying state legislators to correct it. So now they're trying to basically because they want Congress to come after these agencies for like price gap.
Oh, wow. Oh, they taking it to a whole different level.
Oh, it's about to get ugly, and so much so. I even heard that they are planning a million nurse march in Washington D.C.
Oh my God. Oh my God. These
Yeah.
folks are angry. Well,
Yes. Yes.
wow.
And this
So I
this is all
wonder, is the opposite true? If I come in as a nurse with coding information, how what does that look like?
ain't gonna help you at all. It's like those. I mean, it. I'm not gonna say it won't help you at all. It'll help you with documentation because you definitely know that you have to document as a coder. It's all about documentation, so that would definitely help you. And
Oh,
you would
not me
already.
personally. I'm just because
Oh, I'm just saying.
who's not going into nursing would be me. Even though my mother
Yeah.
keeps telling me, "Oh, you would make a wonderful nurse. You make a wonderful nurse." Ma'am, I care and love you. But yeah.
It's different. Yes.
So wow, wow.
Yes.
Here we go. Not only do we have to fight, I feel like Sophia. All my life I had to fight.
Yes.
Oh my God. I gotta fight these doctors. I gotta fight these health plans. I gotta fight these regulators. I gotta fight lawyers, particularly in the compliance space, because now lawyers who don't want to do their own private practice, they want to come in and be compliance officers. We gotta fight them. We gotta fight now. We gotta fight nurses that want to be in health information. Even though the nurse fight has been something that has been going on for decades, actually, but um, with the changes and everything that has been as a result of the pandemic, it's just going to be even heightened and escalated. So I'm gonna have to reach back into my resources and find out, well, what is HIM doing to for this? They may be welcoming, or are they? We'll figure out. We'll find out.
I think. See, I think that this is where the whole. I
What?
don't know because you know how I always talk about gatekeeping
Mm-hmm.
because this has gatekeeping written all over
Mm-hmm.
because there are certain people will. I already know there are people who have opportunities handed to them
Mm-hmm.
because they reach out to me.
Mm-hmm.
I've told you the story about the woman who was she worked in labor and delivery for 20 something years in
Mm-hmm.
hospital, and she got a new job as this working in CDI
Mm-hmm.
and knew nothing about coding, knew nothing about CDI. And she wanted basically she wanted to reach out to me for a crash course in coding. Now I can give you a crash course, but you got to pay for
Yes, sir.
it.
All day.
So that I mean I don't know. That's like somebody hiring you to be a coder, but you have not even you have not taken any ICD 10 CM, nothing. Like you really know absolutely nothing. And that's how so I'm like they have literally handed this woman a six-figure industry change because once she gets a year under her belt, and if she goes and gets a CDIP or CCDS, she can write her own paycheck.
Mhm. That's true. And I know, because they do love nurses over in the CDI space. Woo, those CDI,
But
now those health information folks in CDI are going to be in the fight for their lives.
the thing is, I would love to know why. Why? Because I mean, being a nurse and being a coder, the like I've said this a million times. The only thing being a nurse has given me the advantage of is I'm not intimidated by providers. That's it. Like some people, when you're first in the industry as a coder, you probably put the doctor on a pedestal. Oh, I can't say that, or I can't ask that. Yeah, you can.
Yes, you can, and you should. You better.
Exactly. And as because they have no problem, trust me, they have no problem throwing you under every bus they can. And they will. They're never
Every
going to
bus.
make a mistake. Never. You will be the fall guy all day long.
Yes.
If you don't stand up. So that's the only advantage that I can see. But as far as, making them better, no, because to be perfectly honest, I don't know what does being able, so okay, you've hung blood and you've done, you've done IV push, you hang IVs. What does that have to do with determining if this secondary diagnosis is an MCC or a CC? Nothing.
Right. That's interesting. That's interesting. So do you think at a different level of nursing brings a different skill set? So, maybe not a 2-year RN, but maybe a BSN or MSN? I mean, do you think that? No? Okay. I was just wondering. Curious.
Because clinically, they all do the same thing.
Okay. Well, that's interesting. But yeah, we're going to be in the fight of our lives, and health information professionals, we got this.
Because the thing is, nobody is talking about it. You've heard it here first. I am the canary in the coal mine. These nurses are going to come, and they're going to
spill the tea.
Now is the time to get in and get your credentials, because otherwise it's just going to be hard. Once they get a pathway, and once they get a couple of them in there, and they start advocating for their coworker. I mean, I had a woman reach out to me yesterday. She lost her job at the hospital because she doesn't want to get vaccinated. So she wants to work from home. So I told her, but newsflash, there are remote jobs that require you to be vaccinated too.
Right, because if they're working for a facility that receives federal funding, that mandate it has nothing to do with you, whether you are stepping foot in that facility or not. If you are an employee of that facility, you're mandated. Yeah.
My current job is in Tennessee. I never have to go there. I haven't been there, and I had to send in my vaccination card.
Yep. I wonder. So the only thing I can think that, and I've heard this before from nurses, indirectly, I guess, is but we talked about their takeover spirit, but that's a whole other conversation. But they're the wanting to diagnose or wanting to add their clinical knowledge or clinical background and adding more into what it is. Because really, as a coder, you're taking what you are given and either trying to find out or find the pieces to make it better. Meaning, if there's some things that need to be further documented, then you're querying the provider who provided the service or provided the information or did the assessment for the diagnosis.
Right.
But not, taking your own knowledge, because even as a coder, you can see, well, wait a minute, clearly this is here, this is here, this is here, this is what this should be. But it's not your job to do that. And
That's
nurses, that may be a challenge there, because they may want to insert. And so that's where the frustration for them may come into play, because that's not your role as in health information, as a coder anyway. That's not your role.
Well, that is like the biggest challenge. Like, I'm telling you, like clockwork, like week 3 in my course, that's when reality sets in, because they all will say, "Oh, I didn't expect it to be this challenging," or "I didn't know that it was. I thought it was going to be more simple than this." I said, "Everybody thinks that." Everybody, and then I said, nurses. I said, trust me, I am one, and when I work got into coding, I only worked with nurses, and I've been in trainings, and they want to go back and forth over the smallest thing. It's not that hard. If they say just code it like this, code it like this, and let's just move on. I'm trying to go to lunch, okay? You know, I don't have, you know, I mean, it's not like don't reinvent the wheel. It's already been it's already here.
Right.
Just do what they say. Like just because it's a totally different role.
Right.
And they want to go, then they don't realize, because I'm telling you, like when I know exactly what to do. I mean, when I get in these scenarios, look, you could hear, as my mother would say, a rat pee on cotton. It gets quiet. I'm like, hello, where's everybody? Like, why is it taking you so long? No, you should know these guidelines. This shouldn't, especially when we're in week 3 and we cover week 1. You got to have that down before we, coding bills is continual.
Mm-hmm.
You never stop. And just because you're on chapter 20, if you have a condition from chapter 2, you got to know those guidelines and know how it applies,
Exactly.
how it affects what's going on in chapter 19.
Because oftentimes, especially in an inpatient setting, you have multiple diagnoses. You have a whole laundry list, and you have to make the connections between diagnoses. Yeah.
And I tell them, I tell everybody, when you get finished, you're going to appreciate it, because I don't give them easy questions. Like when we move into, like, especially like the adverse effects and pregnancy, I give them questions where they have to find like 7, 8, 9 codes, because that's reality.
That's reality. That's reality. Those scenarios.
And if you listen, and if you follow the rules, if you do the steps that I tell you, you will always be able to code it.
That's true.
And I don't do multiple choice. You got to find the code.
Yeah, my classes is the same thing. I don't do that. Nope.
And I had this one scenario. I'm going to send it to you. I had this one scenario on sepsis, and it is really, really good. I mean, I have offered a $50 gift card for anybody who can code it correctly, and to date, nobody has ever coded it correctly.
Wow.
Because they don't read. All you got to do is read.
Reading is fundamental. I say that all the time.
And you always, everybody's looking for shortcuts. No.
Yeah. Oh, that's part of this whole profession. You have to read. You have to be engaged in understanding what's happening, reading those patient charts, reading other documentation that's part of the chart, reading the guidelines and the guidance, and reading the regulations. So there's a lot of wonderful bedtime stories that you can be told.
And early on, I do a whole presentation on meat. Because that is what you need to know. Like all the time, there are providers that are going to misdiagnose these. But if you know meat, if you know what has been treated, what has been evaluated, what has been assessed, what has been monitored during that stay or during that encounter, that allows you, per the UHDDS, to diagnose this as a secondary diagnosis.
Mm-hmm. Yeah. Wow. Look at it. Okay. Look at it. So I will spill a little more tea. So next week, we are going to delve into CDI, and we have a guest that's coming on with us to talk about a checklist that he created for the CDI process. And so join us next week when we dig in. I'm not sure if you've been in the CDI space at any level, you've probably heard of Glenn Krause, and so he's going to be our guest next week, and I'm excited. We can pick the brain of a person on CDI. And he may have some comments and commentary. I know he has some comments. There is no he may. I know he has some comment and commentary related to the nursing influx in CDI. So this is going to be fun.
Oh my God. I'm so excited.
It's going to be fun.
Yes. Please tell him to speak freely, because I know he has.
Oh, he does. He does. Trust me. I met him. He came to Cincinnati. Well, I've met him a couple times. I met him personally. He came to Cincinnati when I was working for a particular organization, and there was an opportunity for him. And so we got to talk, and so we've been reaching out and talking to each other for years ever since then. And then I had him, I had recommended him to provide a session at our annual trade show for AHEMA, and so he did that as well. So yeah, we've been knowing each other for a while, and he don't bite his tongue. So it's gonna be fun. It's gonna be fun. Nurses, hold on to your caps. I know y'all don't wear them anymore, but hold on.
Yeah. I know he has a whole rotation of stories.
Yes, yes. So, well, thank you all again for joining the Saturday morning tea. Of course, I gotta ask, was the tea spilled today?
I feel as though it was, because it's spilled every week. I'm telling you.
Wait! Before we go, I see we got people up on the stage. I see
Okay.
Terry. I see Selena.
Okay.
Come on.
Oh, that's right.
We'll
Oh,
give you
Selena and Terry. Yeah. Okay.
Feel free. Now y'all came up here. Okay.
Hello.
Hi.
Good morning.
Good morning. How are you?
I just want to say hello. I haven't said anything. I'm just listening, and I love the tea that y'all giving it the truth and giving it raw, not sugarcoating anything.
Thank
but
you.
I'm just in the process of studying, trying to prepare myself to take this exam. Yeah, and that's where I'm at.
Cool. Well, thanks for joining us, and thanks for coming to the stage and saying hi. I appreciate that.
You're welcome.
And Selena, you're up on the stage.
Hi, good morning, everyone.
Good morning.
Morning.
It's me, Tagua, but I put my daughter's name.
Oh, okay. Oh,
yeah. This is just short. This is my second time in the room, but it's a nice cup of tea in the early morning. It make me energy, give me a lot of energy. Yeah.
Cool. So coming in as an alias. All right.
Yeah. No, for me it's early, especially on my off day. Yeah. But I'm asking if, because all the topic is deeply with the professional in coding and billing, in coding and nursing, why did you put a little, like 15 minutes only for the beginner like me? Next week is going to be the first class for me in the coding. Just hopefully give us some check and tree. How can start? What is the mistakes I can avoid it from the beginning? Where I have to focusing, and how can I study?
Learn your guidelines.
Period. Stop right there.
You can stop right there. Learn your guidelines. In your manuals, you have coding guidelines. Learn them.
Yeah. Because they sent to me 3 huge box. Oh my God. I want to fall down.
Welcome to coding.
Yeah.
Now, in each one of those huge books, so not only do you need to learn the guidelines, but also take a moment to go through the introduction pages. The introduction pages gives you information on how to navigate through those books. It tells you what's in those books. It tells you, what the various sections are in each one of those books. So become familiar with that, because hopefully as your instructor guides you, you'll already be familiar, and you're like, oh, okay, yeah, this was in the introduction, and it told me that this symbol meant that, or that this index was for this, or what have you. So go in prepared that way. So don't just wait for them to tell you to open that book, crack open that book now.
Of me, they say hi for you. All the books, ICD and HCP, CS, I believe so, and CBT. Oh my God, it's hopefully I can do it.
Oh, you'll get it. You'll get it. You will get it. You will get it. It looks daunting and it looks intimidating at first, but there's a method to it. There's a method to the madness.
Of course. Thank you very much.
You're welcome.
Learn your guidelines and make flashcards.
Okay, I will do. This is the first tip. I'm gonna do it. Thank you very much. Have a great day.
You too. Thanks for coming up.
By the way, added my friend. She's named here Samra. She's a down. Okay. Summer. and she's also gonna start the same class with me.
Okay.
And she's in the down. I don't know if she have anything to add it. She came later because she was working,
Okay.
but hopefully she gonna understand what we're talking about it.
Okay.
Thank you very much.
You're welcome. Well, welcome some more. Hopefully you will come in or come back and yeah, get some of this tea that will help you progress and become successful in your professional coding endeavors, starting with that certification exam.
Definitely.
Okay, so again, we feel like the tea has been spilled. Yes, yes, yes. My tea is a little cold now, but it's been spilled. So if this information was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the channel. And as our friend did, make sure you tell a friend. Bring a friend into the clubhouse, bring a friend to the stream, bring a friend. Sharing is caring. Bring a friend. You can also check out the Coding Nurse channel on YouTube, and make sure you check them out today at 11 a.m. Eastern Standard Time. 11 a.m. Eastern Standard Time. He's gonna have that what do they call the very first show? There's a term.
Oh, inaugural?
No, for a show. There's
Premiere?
Premiere.
Okay.
The premiere of his show. Yes, yes. Last but not least, for my Clubhouse folks, make sure you click on the greenhouse to join the fun in our club, and you will get notified of our live broadcast, in which we come in on every Saturday at 9 a.m. Eastern Standard Time. Again, this has been a great session. Thank you, Tasha. You're always there listening. I appreciate you. She says she likes listening to us while she's doing what she's doing. So I appreciate you. Thank you. And thank you for letting me know that we had some technical challenges on the Facebook or on the YouTube side. So thanks for reaching out and telling me that as well. But all is well. Thank you. We will be double checking the system. I did well. I got rid of some of the hissing and the hum, and I don't have the headphones on anymore. I got my other mic. I was like, we was ready. So I don't know what I did, but hopefully I'm not. The problem is I have to move this system into another room because I teach line dance classes. Look at me. I do it all. And so this is the system that I use for that as well. And so I move my system back and forth. And I think that's what's I may have to invest and just have a whole separate system over there and a whole separate system over here, so that I don't mess this up. But anyway, thank you all for joining us today. It's been a great session. As always. Again, thank you to my OHEMA members for their vote of confidence in electing me as their president-elect for 2022 and 2023. I really, really appreciate it. That was love. That was love. Provides me some additional look into some of the things that are happening on our state level. As a director, it's been fun, and I hope to serve you all well. So thanks again for the vote of confidence. Remember, be safe. I know there are people I know we got all kinds of ice, snow. I haven't left the house since Wednesday. We got ice, snow, and everything. Please keep safe and stay warm. And if you don't have to be out there, and if it's a mess out there, don't go out there. It's not necessary. But remember, be safe. Do you have any closing remarks you want to make, Mr. Jesse?
No, I don't. I just, once again, I just enjoy weekly. I just like sharing and being in a space of people who are passionate about, the HIM industry.
Yes, that's how we all connected from the first place. So remember, be safe, be kind, and don't wish for it, work for it. Until next week, take care, and thanks so much for watching.